Ortho.
Hello, everyone. Good evening in India. Thank you for joining the meeting. We're really excited to discuss these two topics with you guys. We're going to start first giving an introduction of Gary Bledsoe. He's our Vice President in RD for BREG. He has been with the company for many years already, 32 years if I'm not mistaken. And he has over 45 years of experience at leading the orthopedic product design within BREG and then with Bledsoe as well, a company that we merged a couple of years back. He's the man holding a large number of patents on orthopedic bracing. Among this, the dynamic bracing, he's the inventor for bracing in dynamic bracing. And as well, I want to introduce Graham Ganshirt, which is our new cold therapy product manager, which has a lot of experience as well in this field. He's going to be talking with us about the difference between the clinical advancements in cold therapy and compression by themselves. So he's going to explain about the difference between those two systems and how they improve the quality of a patient. And we can go ahead, Graham. We can start. So let me share my screen so you guys are able to see this.
Perfect.
We have it.
Thank you.
Perfect. Well, good evening, everyone. My name is Graham Ganshirt, as Marta mentioned. Gary has a few more years on me at BREG. I've been at BREG for just about 6 months now, but very excited to talk to you all today about the polar care wave, but more specifically, the clinical advantages of cold and compression therapy. So we're going to begin with talking about solely the effects of cryotherapy and the benefits from cold therapy. Then we will transition to the clinical advantages of cold and compression versus cold alone. Next, we'll look at cold and compression in the post-op pain management space. I think I'm getting some feedback. There we go, perfect. And I pulled an existing study that I've looked at for hip arthroscopy. So we'll look at some examples there and some of the results that they were able to show. And then we will move on to talk about our product, the Polar Care Wave, and we will discuss the benefits, features, and then the financials from the past couple years. And then lastly, I just want to open up to some questions and answers. If you do have any questions along the way, please feel free to stop me. I'm hoping this can be interactive and a little bit more informal. But again, yeah, please feel free to stop me, and excited to talk to you all today. So first, we're going to talk about the effects of cold therapy and the benefits of motorized cold therapy. So the first is from the evidence in the study that I've looked at, we know that lowering the temperature of the joint space prevents discomfort and swelling after the surgery for the patient, which also is going to reduce pain. This is very, very important. So looking at BREG's cold therapy devices, our devices are consistent and provide comfortable temperatures for hours for this optimal cold therapy. And you can compare this to other methods and practices that people may be using instead of these devices, which is standard ice packs or gel packs. And we know that these quickly melt. They're only comfortable for a certain period of time due to that extreme low temperature between the skin and that meeting point of that ice pack. But it's messy. The ice melts fairly quickly. It makes your skin wet. If the patient is more immobile, it's harder for them to get off the couch or off a chair. Go refreeze their ice pack. So there's many, many reasons why it is not the optimal cold therapy method. The next is from studies that I've looked at and also more empirical data is people that are using cold therapy, more likely than not, it reduces their narcotic use, which is very, very important. And we're going to talk about a little bit more of that when we add in the compression side. But any way that we can reduce narcotic use for patients, I think is super, super important. And then lastly, not only are the patients benefiting from this, but so are the physicians and the doctors. When patients come in for their follow-up, the focus should be on recovery rather than pain management. So instead of your patient coming in and just being in excruciating pain, You can work on that road to recovery for them, for that range of motion, and to get them back to their day-to-day activities as soon as possible. So these are just the benefits of cold therapy, and we will transition to the next slide to talk about when we add in. They kind of go hand in hand. You may see some similarities between my last slide and this slide, but there are a ton of examples and a ton of studies why adding that compression does so much for the patient. So better short-term pain control for the patients, so better swelling reduction, more pain control, and then again, we'll look at this on the next slide in an example, but for hip arthroscopy specifically, the patient had much less blood loss. And I know this is really important for physicians and doctors too, particularly during post-op recovery. And then I think this is super important as well. And I'll pull some examples too in the next couple slides, but patients are more likely to be discharged from the hospital sooner. We know that the cost burden on hospitals, when patients have to stay even just a couple days longer, and the patients want to get out too, right? They want to get back to their day-to-day activities. They want to improve their range of motion, and then recover, at their home. Perfect. Next slide. So here is an example of a study that I pulled from the Journal of Hip Preservation Surgery. And really, this study looked at 40 patients that were split into two groups. So group 1 was using compression and cold therapy, and group 2 was only using cryotherapy or that cold therapy. All patients were seeing the same doctor, so they were all prescribed the same protocol, meaning 30 minutes on, 30 minutes off for the cold and compression device. And the procedure that was done was a hip arthroscopy. So the results are quite fascinating to me. They surveyed all the patients and gave them a scale of 1 to 10 while they were recovering. And the cold and compression group displayed a significant lower pain level. So the cold and compression aspect really improved the reduction in swelling, as well as their pain management. Now, I think the next point for me specifically is probably the most important, and this was the amount of narcotic opioid doses that each group received. And you can see that the cold and compression group received over just roughly 1.5 doses, while the cold therapy group, requested just under 3. Relatively close. So I think the compression aspect really does speak volumes. Narcotic opioids that doctors do have to prescribe. Next point here was that 20 out of the 20 cold and compression patients were able to be released after day 1, compared to the cold therapy, just the cryotherapy patients, 17 out of 20 were released after day 1. And then lastly, at the very end, they surveyed the patients and action with the cold and compression device, and they believe that it improved their level of post-operative pain. So 4, I think, very crucial points here. Cold therapy, cryotherapy is great. It has fantastic benefits, but really when you add that compression feature, the results speak volumes. So significantly lower pain levels surveyed by the patients, less narcotics, patients are able to be discharged sooner, and then 18 out of 20, which is a great percentage, were very satisfied with the compression aspect. Next slide, please. So one thing I spoke about in the last slide was post-op complications, and then more importantly, readmissions and that I pulled, and unplanned total knee arthroscopy as well as total knee replacement readmission rates are 4.3% with an average stay of 3 days. And the cost burden, depending on, where you are, I guess it varies hospital by hospital, but each day a patient stays can result in thousands, if not tens of thousands of dollars. And then secondly, 13% of the orthopedic readmissions are due to pain and post-op complications. So I spoke about that a couple slides ago about the clinical advantages of adding that compression aspect, which significantly helps pain for the patients, as well as those post-op complications where they can't get back to their day-to-day activities. So I think these two statistics also speak volumes to the importance of cold therapy plus that compression, getting your patients out of the hospital sooner and getting them back to their day-to-day regular activities. Next slide, please. So there is a very, very, very big opioid epidemic. Also, it's in the entire globe. So track and minimize the amount of opioids that need to be prescribed and distributed to their patients. And I think we are all very well aware of this. You watch the news, you pick up the newspaper, and you see stories about opioids, all over the place. In another study that I looked at, up to 25 of the patients requested alternatives to opioids for their pain management. So I think this is where our BREG devices, specifically the Polar Care Wave, comes into play. So any type of alternative method that you can use to not prescribe opioids or just prevent patients from using them, I think is very, very important. I was just on the road traveling in the United States a few days ago and spoke to a doctor who has now been using our Polar Care Wave for a few months now. And he said that he is almost never prescribing opioids anymore. He's given his patients the Polar Care Wave. They absolutely love it. Their pain levels are down tremendously, and they don't want to take them. We all know the complications of what opioids do and the side effects that they have and the risk of addiction. So again, just doing everything in our power and trying to help people out. And then I pulled some statistics from the WHO website, and in 2019 worldwide, approximately 62 million people used opioids in the world. And then furthermore, each year worldwide, 500,000 deaths are attributed to drug use, and more than 70% of these are related to opioids. So again, this is not a continent by continent issue, but this is a worldwide epidemic. And I think, BREG is doing everything that we can to help patients and doctors not prescribe as many opioids. Next slide, please. And then looking at our product, the Polar Care Wave, 3 things that I want to highlight specifically. I think some of you are all familiar with this product, but if you're not, it is simple, it is customizable for the patient, and it is very, very the system alone. You can purchase the system as a combo unit that comes with a pad, or you can customize it any way you want. So we have a universal pad that can be used all across the body. We have a knee, we have a large knee option, we have a shoulder, a back, a foot and ankle, and a hip pad. So again, very customizable and great for all different types of surgeries and procedures. Next slide, please. Here are some of our financials. These are our units sold over the last now 3 years. So we launched this product right at the beginning of 2020, which we all know was a pretty interesting time with the pandemic and COVID-19. So I really think these numbers and the growth that we see speak volumes to the impact that this product has on the market. So obviously with COVID-19, as I mentioned, and surgeries, some surgeries being rescheduled and some surgeries not happening for extended periods of time, just the growth that we have seen from 2020 to 2021, and then furthermore to 2022 is just fantastic. So if you go to the next slide, I broke it down a little bit, not so much just a chart, but I looked at just the Wave devices, the quantity sold. So this is the unit itself plus the combos. So from 2020 to 2021, our units sold grew 258%. In addition to that, from 2021 to 2022, and this is just through November, our sales have grown an additional 72%. So fantastic growth. I don't see this slowing down anytime soon. We have a ton of opportunities lined up in the pipeline for 2023. This product is spreading like crazy, and it's really the first single patient use product to market. Other cold and compression devices that you see, they have to be rented out. They're capital equipment. They don't belong to the patient. Most patients need them longer than that rented period of time. So it's really true. And then lastly, I pulled in our pads here, our add-ons, as I like to call them, and our units grew 62% from 2020, from that initial year to 2021, and then an additional 33% from 2021 to 2022. So fantastic growth. Next slide, please. And I'll just wrap it up here with just some key takeaways, and then we can get into some Q&A. But I want to highlight, again, those clinical benefits of cold and that compression setting. So better short-term pain for the patient, less blood loss, greater likelihood of independence from narcotics and opioids. It improves the range of motion during post-op recovery for the patient. And then lastly, patients are more likely to be discharged from the hospital sooner. And then highlighting our Polar Care Wave, again, single patient use, cold, and it has the compression feature. It's simple, it's customizable, and it's very convenient for the multiple pad configurations. So whether it's your knee, hip, back, shoulder, universal, or foot and ankle, we have you covered, and we're happy to help the patient in any way that we can. So thank you very much, and I will open it up now to questions, and hopefully I can provide some answers. Yes, we have a question.
Yeah, it's a nice presentation.
Thank you.
Graham. Yeah, like my question is, like in the post-operative period, in the immediate post-operative period, where do we apply this ice pack exactly? Over the dressing or adjacent to the dressing in the normal skin? So how does it work?
So the Polar Care Wave does not require a dressing. So we have a built-in barrier to the pad that can go directly on the skin. This is a little bit different than our other cold therapy devices, such as the Cube or the Kodiak or the Glacier, if you're familiar with those. Those do require a barrier. The Wave has a built-in barrier to the pad itself, where it does not require that extra dressing.
Okay, so directly
again,
over in the operative site, I can apply, like we can apply directly this pad, your cold therapy machine, is it?
Yeah, if the wound needs to be covered, absolutely, you can still use a dressing or a bandage, and then the pad can go right over that. So that's another great benefit of the product itself.
Okay, thank you.
Thank you. Okay.
I'm Krishnamurthy, sir. In post-operative case, from day one onwards, we can give the cryotherapy. So if the wound and sutures are there, so how could we apply? Can we cover the dressing, except that surgery area we can give, or otherwise any protocol? Do you have this, sir?
Yes.
Is the question around the protocol?
Yes, sir. For post-operative cases, for example, TKR or THR patients, sir.
Yeah, so the protocol is going to range physician by physician. There really is no set specific protocol that's given out. So the most common one that I hear is 30 minutes on, 30 minutes off. But again, this is going to vary patient by patient, procedure by procedure.
How so cover the suture area except that should be treat except that surgery area by Crave?
Yes.
Could
Okay.
you repeat that again? Sorry.
So if we for example TKR patients, so we are giving cryotherapy means, so should we treat other than surgery marking area, sir, for reducing the hematoma like that?
I'm having a hard time hearing. I think it might be my audio. Gary, can you relay the question?
Yeah, basically he's asking, what all has to be in place and how does it affect the hematoma, et cetera. This can be used directly over thin bandages. You don't need any thick ones. You don't have to worry about anything else. In terms of compression, the compression levels are quite low on these devices. They're in the range which will not restrict blood flow. Cold is pretty good at reducing the accumulation of new fluid, new inflammation. Compression is much better at taking away the inflammation that's already present. And when you put the two together, it makes a big difference. You don't have to be concerned about the hematomas. Now, this is not a DVT pretension device. We have one of those as well, the V-Pulse, but it's perfect for direct wound compression post-surgery. And as he mentioned earlier, can be applied directly in the OR. So simply apply whatever steri strips, cold bandages, keep them thin. The thinner, the better. But you don't have to do anything special. You don't want giant thicknesses of bandages because those act as additional insulators and will reduce the efficacy. But used properly in that one area, you'll see considerable differences. And the second thing that compression does that is very important for the cold aspect is compression brings the pad into more intimate contact with the skin. And so your actual thermal transfer rates increase a lot. And this is one of the things that makes it so much more effective than simply cold alone. Okay, does that help answer the question?
Thank you for your explanation, sir.
Thanks.
How to prevent cold burns in post-op conditions, sir?
Yeah, so with the wave with that barrier built in, we recommend checking the skin every hour. But since that barrier is built in, this reduces that chance of having that skin burn. And then in areas where we know that it's more prone to see a burn, such as the foot and ankle, that pad temperature does not get as cold. So as I mentioned, for other pads, our coldest temperature is around 40 degrees Fahrenheit. For the foot and ankle, the lowest temperature that it'll get is around 45 to 50 degrees.
Thank you.
Or 50 degrees, I'm sorry. 45 is the lower temp, so around 50 degrees.
Oh.
Reviewing the literature from the entire world, temperatures of greater than 5 Celsius, there is virtually no chance of having non-freezing nerve damage or freezing. Okay, so you don't have to worry too much about that. It's quite a safe device.
Okay. Oh, one more question. Yep, go ahead.
Like this is not regarding post-operative pain management. It's just after any soft tissue injury, for instance, ankle sprain.
Yes.
Okay. So in those scenarios, do you recommend using your device, like ice compression device?
Yes.
Yes, absolutely.
Yeah. The question is because there are some studies, they say that ice decreases the inflammation that like potentially helps in healing of the tissues. Like ice can cause like decreased angiogenesis, decreased vascularization. So because traditional teaching is rest, ice, compression, elevation. So the rice therapy,
Yeah.
they used to say. But
Yes.
there are some latest studies, they say that even anti-inflammatory medicines and ice should be used with caution, so that will not impair the wound healing. So what is your take in this?
Would you like me to cover this one, Graham?
Sure, go ahead, Gary.
I'd be happy to. The key word, your key magic word that you mentioned is ice.
Yeah.
We're not using ice. We have a thermal barrier built in. We're maintaining temperatures above the levels that typically cause the difficulties with cold ice products. So the key here is not to get it too cold. There is an efficacy range, which is like a big curve or a plateau in the middle. And you need to be at temperatures of greater than 5 Celsius, and typically 6, 7, 8 Celsius are perfect temperature ranges. And you see a reduced effect when you get above about 11 to 12 degrees. It starts to go down on the opposite side. And that's the cold component. And when you add compression to that, you must be additionally careful because the patient will sense that the temperature is colder when the compression brings that pad into intimate contact. So, for example, a non-compression device running at 45 degrees, right? It's not going to feel as cold to the patient. It's going to feel more like 48, 49 degrees Fahrenheit. But when you're using compression with it, 45 degrees will feel like 41.
Okay.
Pardon me. So you have to be careful. But yes, the devices are safe and they don't get into that danger range, which actually would cause, well, let's see, it will slow down the healing rate of the patient. That's at the very lower end of those temperature ranges. And these devices don't do that. Okay. Thank you.
Yeah. So you mean less than 5 degree like Celsius can impair, but the device sets between 5 to 11 or something, right?
Yes, of course.
And do we have control over?
That's true worldwide, that what we've seen.
Okay.
All of the literature, in fact, interestingly enough, in some of the literature, they even have tested immersion, complete immersion in water at 5 degrees Celsius for longer periods of time. And they still don't see non-freezing nerve damage, and they don't see any type of actual burning, right? So those are fairly safe temperatures. Now, the older the patient, the lower the circulation, the more you want to be to the upper side of the scale. So I have a kind of rule when I put for every 5 years that the patient is older than 70, I add another little thin piece of paper in there, the little thin thermal barriers, if you want them, because these patients will cold soak much easier. Now, they're still not going to get their skin temperature below the lowest range that the devices are set for. So you still are not going to risk non-freezing nerve damage, and you're still not going to risk any type of frostbite. Okay? But your comfort levels will start to drop, and your efficacy will start to drop if you get too low on that scale.
Okay. Good.
Thank you.
And do we have temperature control in the machine that we, as a provider, we change, or?
I think it's set up at you have 2 compression levels on that one, Graham. You have a slightly higher one and a slightly lower one. So you can use the lower one if you have a specific question about it. These are not at levels which would create restriction that might cause, particularly around the knee or other areas, that might cause any type of DVT or increase the probabilities of DVT. They're low enough not to have that. In fact, by maintaining some of that pressure immediately from day one, you can reduce the possibility of DVT as well. It's just not specifically set up to address DVT. That's our B-pulse unit that's capable of doing that.
Yeah. Thank you, both of you.
Welcome. You're welcome.
Thank you. All right, Gary, should we transition over to your portion? I want to make sure you have enough time.
Graham, before we moving to the next part, I think we have a few questions in the chat box.
Okay, perfect. I can answer those in the chat if that's okay, and I'll let Gary go ahead and get started. because I want to make sure he has enough time. So I'll reply in the chat to those.
Okay.
Thank you.
Okay. So are we ready for me to pull up my presentation?
Yeah, I think Maritza has it.
No, I have it too. She doesn't have this one. Whoops, what happened here? Okay, now can you see my particular presentation? No?
Yes.
You do see it. Excellent. I don't see it. And I don't know what happened here.
Make it a full screen.
I tried to put it on full screen. Oh, here we go. There it went. Ah. Now, can you see this?
Yes, perfect now. Perfect.
Perfect. So very, very well. So first I would like to say namaste and talk a little bit about functional OA and ACL bracing in the dynamic sense to get you to understand what this means. Functional ACL dynamic bracing is a little bit different, and we're going to address ACL before we do OA. But dynamic bracing is basically the use of movement or muscle power to apply a force at the moment of need, and then remove that force when no need exists. So this is basically muscles working against the pathological movement. So in the case of an ACL, we need to prevent subluxation anteriorly. So we apply increased force as we move into extension. And then when the leg moves back into flexion, we take it away. Now, dating back into the early 80s and even before, but this is one of the earliest published studies by Renstrom, in which the quadriceps muscles were detected to cause anterior tibial translation in the last 30 degrees of extension. So we knew this quite early. We didn't know all the other details. In Beard's work in Great Britain there, the hamstrings reflex is actually considerably slower in ACL deficient knees. And it's because the primary reflex comes from the ACL, which is now missing. So on patients that are ACL deficient and symptomatic, there are four things they can't do. They can't stop, run downhill. They can't land from a jump, and lateral maneuvers are affected. All of these can cause instability in those patients. The common key here is that all of these movements have an open kinetic chain phase in which the knee is more extended as the knee sweeps out, and that tibia subluxes before foot strike. So we don't have the availability of all of the other muscles that might help to prevent tibial subluxation with the foot in contact with the ground. This is free subluxation. Okay? And this was briefly mentioned by Andriaki back in 2005, and all he did was confirm what we already knew at the time, which was great. But one of the earliest ones to show something on it was the late, great Bob Jackson. And this is from a poster exhibit that was put up at ESCA 2000. And on the left is heel strike. And then one complete gait phase to the 100% end on the right is heel strike again. The unaffected leg has been shifted 1/2 cycle to overlay so that you can compare the two. The green was this particular patient's curve going from heel strike through the various phases of the gait until the next heel strike. The blue range is, we won't necessarily call them normal. This is all the range of both normal and ACL deficient knees that had no symptoms whatsoever. Well, I think it's important to understand. The red curve shows exactly what happens. So starting out at heel strike, you'll notice that the tibia is already subluxed about 16 to 17 millimeters. And then it goes through the range of motion and then swing and then extension. And when you hit again over to the right, it's again subluxed. And this is part of the problem. It's very difficult to prevent this from occurring in that open kinetic chain phase because you don't have other muscles to help you. First of all, it is the compression of the sublux condyles at foot strike that actually prevents the tibia from reducing when it should. They have to go through a little bit of a flexion cycle, eccentric deceleration cycle, and a flexion cycle until finally joint shear force or body shear force and flexion angle overcome this condylar compression, and then you get this sudden and violent reduction, and usually the patient goes down. And Hirakawa in his work also said no matter how much muscle tension and force you have from the hamstrings, they cannot control the tibial position in the last 15 degrees. That's important to understand. Just training of the hamstrings is not going to it's going to help, but it's not going to completely prevent the problem, because that last 15 degrees creates a situation that the hamstrings aren't capable of handling. So dynamic braces will then use the power of the quadriceps muscle, which is causing the issue, and we're going to turn that into a special translation in the hinge. And this will increase these forces as you move into extension in that last 30 degrees. Salomanow did publish a paper. This is a very interesting paper. This particular one was his outgoing presidential address at this particular annual meeting of the Journal of Electromyography and Kinesiology. It's a fascinating article. Anyone who wants to understand a lot about dynamic bracing and other issues involved in the neurosensory role of ligaments should read this paper and study it. It's great. Here's a dynamic brace, and I want you to concentrate. Can everyone see the movement? Is it working okay? Coming through?
Gary. Yes.
Very good. Okay. So I want you to concentrate on this small silver lever that handles the proximal anterior and posterior tibial strap. They are connected to a separate lever. And notice that it's protruding anterior now, but as you move into extension, you see all the posterior movement in that proximal tibial strap. Start here, it's snug, but as you get into extension, it's much higher. That additional lever actually moves that proximal anterior tibial strap 12 to 15 millimeters. That's quite a bit. And that is the additional load that you get from a dynamic brace that you don't get from a static one. So static braces, your strap tension sets your limit. Here you must be careful not to over tighten. If you over tighten, then go into full extension and just stand there and do nothing, the leg can go to sleep. But for sports play, this can prevent that tibia from subluxing. So that is the key to preventing symptomology in an ACL deficient knee. If you can prevent the tibia from subluxing prior to foot strike, then when the foot impacts the ground, the joint is in a conjugate position. And you're now compressing the condyles and rendering some stability in the normal place. This is important because Markov in some of his studies showed that condylar compression on impact, in order to move it from that position, it's almost track bound, is almost the amount of stability that an intact ACL has. In other words, the force that it produces to keep the tibia stabilized is quite high. And if you couple that condylar compression with the graft strength and the muscles, et cetera, then it gets much better. You can stop it. Now, there's been quite a few studies on this. The earliest one was from Acierno back in the late mid-90s. And they had dynamic braces that were applied to patients that had quadriceps inhibition and symptoms of ACL deficiency. And when they applied a dynamic brace, the patients could do maximal effort isokinetic extension. And they got no quad inhibition, they got no anterior translation. And their symptoms were either considerably reduced or eliminated completely. So these things work, and it's interesting to watch them on an athlete going back out to start doing some exercise and work and see how much better they can perform. I'm not recommending you use this in place of a reconstruction, but some reconstructions, ACL reconstructions, take some time in order to schedule them, and you have to do to protect the menisci, the articular cartilage, and other structures during that period. Now, the same forces that you see in an ACL deficient knee, if you do that in an ACL reconstructed knee, you have some issues, right? So those reconstructed ligament grafts have no nerves. They can't signal the muscles necessary to protect them. And if you continue with that approach at high levels of professional athletic activity, and we know that you have a fairly high percentage of stretched grafts. They don't typically fail catastrophically, but over time, they have a tendency to go through creep of the ligament structure, and they actually start to get loosened in that 2 to 5 year time span. We've seen, even for autografts, we've seen failure rates in high-level athletes as high as 25%, and failure rate for allografts in high-level athletes can reach the mid to upper 30% range in that 2 to 5 year time span. And these are patients that might have been protected had they used dynamic bracing. So I think it's important to understand that if you're not doing some sort of biofeedback to help get the hamstrings to control the tibia, you almost have to do something to protect these patients when they return. So you don't say, okay, you can use the brace for 6 months, then don't use it anymore. Unless you found some way to grow nerves back in those grafts, or unless you found a way to provide muscle control through some type of biofeedback training, then that leg is forever at risk. And braces can help. So the strap tension that it takes to control an anterior tibial subluxation in these larger athletes is about 3 times what it takes to block circulation. And so you cannot tighten a passive brace or a static brace enough to prevent these problems. That's why we invented dynamic bracing in the first place. Now let's go over to dynamic OA bracing for a minute. So now we're going to take those same principles, that is applying force at a moment of need and removing them when you don't need it. For osteoarthritis, unicompartmental, about 80% of the patients are varus, about 20% are valgus. And we have braces that have to be applied for different sides of the leg. A dynamic brace for the medial side will not work for the lateral, etc. This is your continuum of care for these OA patients, starting with the least aggressive, moving to the most aggressive procedures. And bracing is right at the next to the lowest category. No real morbidity, mortality that we know of. About the worst you get is some occasional discomfort from braces that maybe aren't. It's very early in the wearing period. They haven't adjusted, or they haven't learned how to quite tighten them enough just to control their problem, but no more. And many of the procedures that you see that follow here, such as all of your injections, your hyaluronic acid, PRP stem cells, debridement, lavage, and grafting and transplants particular, Oates procedures or complete cartilage replacements, meniscal repairs, all of these can benefit from some unloading done by dynamic braces. Now, there are 2 types of technologies on a dynamic brace. There is a push, in which you can see the 3 points there. On the medial side, 80% of the time, if you're pushing laterally, you're pushing in that area that's a little more sensitive, right? That whole iliotibial band area and the side of the knee you have to be very careful about too much pushing. And if the brace slides down a little bit and you can't maintain its position, then the lower part of that condylar pad is starting to get into the fibular neck. You don't want that. So to some extent, I actually prefer using pull mechanisms. And by the way, OA push mechanisms are only available on static braces. OA pull mechanisms are typically mostly available on dynamic braces. The one exception to the rule is a duo, which is a double upright, which one side of the hinge gets longer and the other shorter, and it both pushes and pulls. Now, you can only do a 3-point force in the last 30 degrees of extension. If you look from the bottom of the leg, you notice those force points more or less line up from medially to laterally across the leg. But the minute you move into flexion, you've moved those force points. And you can see the one pushing the knee over in one direction, and the other 2 forces for the lower leg and upper leg are no longer in the same line. And this produces a rolling tendency and the brace will roll in the counterclockwise direction, even if you've put some angular force there. And for this reason, fixed angle braces have a greater tendency to roll. So you would like to put in the force in extension and the angle and take away that force and angle as you flex. Here's a good example. Look at how the angle of the brace is varying from a flex to an extended position. Now, this patient doesn't need this brace in particular. This is a model, of course, and you can tell she doesn't have, she has acute knee, but not acute OA knee. So in this particular case, you see how the forces are increasing when you need them during the walking phase, and you take them away when you're sitting down, so you don't have force and discomfort. These particular dynamic braces have been studied many times. One of the earliest studies was done by Dr. Komastek and Doug Dennis, and was been published in multiple journals and hundreds of podium talks across the world. It became very popular because the patients were walking on a treadmill with and without a brace in a video fluoroscope. And the fluoroscope captured those images, and then it manipulated the images to calculate the delta opening of the knee. This was not some researcher doing the calculation. And the error is about 0.4 of a millimeter, which is very good. So here's a patient. They can vary the pace until they get to a pace that is comfortable for them, walking without the brace and then walking with the brace. And they continue doing this, and the data is all captured by the computer. Now, the computer is also taking pictures at specific points in the video. The two biggest peaks are heel strike and mid stance. Here's an example of a heel strike on the left without a brace. You see we're bone on bone in contact, and the patient's potentially painful. And here you can see the same heel strike screen with the brace in place. You notice it's open. Does it have to be open? No, but it is. On some patients, about 78 patients show some joint separation, let's say greater than the margin of error of the study, while wearing a dynamic OA brace. And more than 92% of those patients experience pain relief sufficient to want to continue using the device. Interestingly enough, on patients that have moderate to severe OA and considerable pain, our compliance rate, even at the end of a year, is over 60%. Patients that have continued to use it all the way to that point. The patients that got no separation or didn't get sufficient, well, all the ones with no separation were more than 20% above body weight. But you note from 78% joint separation to 92% pain relief, several of those patients that didn't completely open by the study, question mark, at least got pressure reduced significantly enough to no longer experience the pain that caused them problems. So they can now go back to their activities of daily living, do some walking and other activities that promote their health and prepare them for their what's to come later on, which will eventually be joint arthroplasty or some other technique or repair procedure. Here's another study published in the Journal of Bone and Joint Surgery. And again, this was commissioned or requested by the editorial committee of the Journal of Bone and Joint Surgery. I think that was the important thing to understand. So Dr. Dennis and Dr. Komastek and Dr. Mahfouz repeated this study based upon the protocol that the journal editorial board suggested based upon income from questions and requests from their audience members. So they chose, again, it's a video fluoroscopy technique, and the top 5 most popular braces were selected. They didn't test any brace that has less than a 5% market share. They didn't feel that we had the dollars to do all this. They chose 5 patients that were diagnosed with moderate to severe osteoarthritis. Every brace that was applied was fitted by a designated company expert for that product. Every patient wore every brace. So you got a chance to see how all these different braces did on all the different patients. CT scans were made of each of these patients' legs, and that allows 3D bony models to be created. And so this technique takes those 3D bony models, the computer manipulates the 3-dimensional bony model and overlays it over the fluoroscopic images. And from that can calculate and compute the maximum opening. This particular type of procedure, as opposed to it says 2D, this is a 3D. The 3D procedure is 0.2 of a millimeter accuracy, whereas the 2D is 0.4 of a millimeter accuracy. Our dynamic braces had the highest average separation by a good margin, and that was in heel strike. By the time you moved to mid stance, which is the second biggest peak in the gait cycle, we were the only product that produced an average separation that was greater than the margin of error of the study. And when you finally get complete rock off just prior to toe off, we were 1.3 millimeters average, more than 3 times greater than the next second best performer in this product. And so dynamic bracing works when it's used effectively. And that's it for my presentations. I first want to say Kodanyavad, and I'll pull the, go back to my screen sharing and turn it off. And I'd be happy to answer any questions that now come up.
Do you have the, the video before bracing and after bracing? With the help
I'm sorry, repeat that again.
Do you have the video before and after bracing in the video fluoroscope, like what you have shown?
Oh, yes. You want me to show that again?
Yeah.
Okay, one moment again. Let me
before and
open that. Okay, I'll show you. I'll show you the before and after one. Let me pull down to here and come back up to this one. Yes. Can you see this one?
Yeah.
Okay. You get a similar, in several of these studies, we not only track the heel strike, this is a heel strike image. We also look at the mid-stance images, and they produce the same results in mid-stance as they do at heel strike. We have a lot of this footage and data from over the years. This study was originally done with 12 patients and then extended up over the years to more than 200 patients, all mostly the same results.
This is the pull brace which you have used in, right?
This is a pull type dynamic brace, yes.
So what you prefer, most of the times a push or pull brace, which is the best one?
Oh, not necessarily. I think there are a range of braces. Well, let me say this. In the dynamic bracing realm, pull braces have been shown to be slightly more effective than push type braces. And since you're dealing 80% of the time with the medial joint, in order to use a push brace, you're over on the lateral side, the IT band in that area, that are a little more sensitive to pressure. And by using a pull brace and going above those areas and to some of the softer tissue, we can get enough movement to reduce the pain without causing too much pressure on the lateral side. But if you have a patient that is extremely valgus, you can't put a push type brace between their knees. You have to go to a lateral pull type brace. If you have an athlete with an ACL problem and OA, you really need double upright to control the tibial component, and you need a dynamic angle sideways like the Duo has to control the osteoarthritis portion. So it varies considerably. Okay.
So
all right,
how long?
I'm going to stop the sharing so I can see some of this stuff again. I'm sorry, would you repeat that?
No, how long, do you recommend to wear this brace?
Well, first of all, if once you get to the point, if you're just talking about patients who are ACL deficient and don't intend to have reconstruction, they must wear it always when they're doing higher activity levels that would normally cause them some symptoms or giving way episodes. And you also want to wear them to reduce the incident. I'm sorry, for OA braces, you wear them all the time when there's pain. And your objective here is to reduce the use of anti-inflammatory medications because those have long-term consequences. So you will wear them until something happens to reduce the pain. Now, do you have to wear them forever? No. And let me explain why. Articular cartilage likes to be loaded in a specific range. If you load it too little, it becomes friable and it breaks off and it's chunky because it can't get good blood supply and nutritional supply to regrow properly. But if you overload it, it will slowly erode away till there's very little left. And if you're doing procedures in which you're trying to get the cartilage to help repair itself, whether it's repair with fiber cartilage or original hyaline cartilage is really almost immaterial so long as you stop the pain. And you have to stop the inflammatory process. A hot, inflamed osteoarthritic knee looks very much like a subchondral fracture when you look at it that way. And if you must unload it enough to stop that inflammatory response, because the long-term result of inflammation is degeneration of the joint at an accelerated rate. And once the capsule becomes permeous, there are a lot of things in that joint that don't belong there. You have to stop that reaction. And you use the OA brace for stopping that inflammatory response and for pain control. They do it as long as they need to do it for pain control. But if they get enough growth of the cartilage, they don't have to do it forever. I've been bone on bone on my lateral compartments on both knees now for at least the last 15 to 16 years that I'm aware of. And I wear the dynamic braces when I need to. If it starts to get a little inflamed or irritated, I put them back on for a short period of time. In the beginning, I would use them for 6 to 8 months. The pain would be reduced. And because everybody doesn't want to wear a brace, I would take the brace off because I didn't have the pain. You need the pain to encourage you to comply. But if you don't have the pain, you tend to stop. I would stop and then I would go another 2 or 3 months without pain. And then the pain would begin to come back and I would have to put the braces on again. Well, now this late into my career, I haven't had total joints yet. I don't think I intend to. I will probably try some stem cells or PRP or something within the next couple of years. I'm 71. I'd like to get to be able to the point where I have less pain without a brace. But now I can typically go more than a year before I have to put the braces back on because I've gotten some cartilaginous repair. And you can improve this by using some nutritional supplementation. You need vitamin B6, pyridoxine, that's the amine and glucosamine. You need the mineral manganese, and you need vitamin C. If you do that, you activate the enzyme, your body makes its own glucosamine, and that helps the repair process. Okay? Other questions?
Gary, there's 2 questions in the team chat.
All right, I see. For chronic cases like OA, that's cold compression. I just see one right now. After isolated ACL reconstruction surgery, how long is dynamic bracing recommended? Isolated ACL reconstruction, it's never totally isolated, is it? You always get some stretch in some of the other ligaments, but you have one isolated failure, quote unquote. We tell them that, first of all, they do not need dynamic bracing in the immediate post-operative period. You start dynamic bracing when the patient begins doing active knee extension that might place some force on the graft that could potentially stretch it in the early rehabilitation period. We encourage them to put just enough compression to keep a nice, comfortable force. And most of the patients sense that force and they feel much more stable and much better with that dynamic brace pulling back in and holding that tibia intact. And then they will continue to wear it during their sporting activities. Many surgeons say they can stop wearing it in about a year because once the ligament has achieved maturation, then it's only there not to control symptoms, but it can be worn after that to help prevent a long-term stretch of that ligament, because as I said before, nobody has found a way to grow nerves back in the ligament. The one exception to that are some of the new interesting techniques that are done places like Boston, where Martha Murray, for instance, is doing an ACL primary reconstruction on younger athletes, particularly children and adolescents, using a technique that covers the repaired ACL with a surgical sponge that's resorbable. And this keeps a nice blood-bound boundary for the wound site that helps prevent synovial fluid from penetrating, and her rates of success are very high on this. And I think what's most important, if this is possible to do these repairs, is that the original nerves are still intact in the ligament. They do come back. But in a regular graft type situation, be it allograft or autograft, they do not come back. No one has ever documented they come back, even up to 8 years post-operatively. Does that answer your question? So these longer terms, if you're going to continue at high-level sports, then you put your dynamic brace on during those high-level sporting activities, both practice and play. You don't want to practice with it and then play without it. That sets yourself up for failure, because you're depending on the brace now as part of the proprioceptive response for joint position sense, etc. If you're going to learn to train the hamstrings muscle, which these braces can do, then you practice with and without the brace, and then until you get comfortable doing this, and then you play without it. There's actually, in that article that I talked about from Dr. Salamanow, there is a technique in there in which they they put the braces on and do these rapid extensions, and they find out that every time they extend, there's a force. Every time they extend, there's a force. And that shear force is going up across the distal hamstrings. And when that force rises very quickly, it's like taking dinging the tendons very close to the joint. You get a tonic reflex. And so the hamstrings fires anyway. And they can continue doing this. The body learns it, like Pavlov's dog. And after some short period of time, you can remove the brace, and the hamstrings will contract based on that habit. And they'll do so as it moves into extension. They've been trained. Now, it lasts anywhere from several days to several weeks. It does have to be reinforced. It's not a permanent response. But this can be used so that athletes can train to the point that they can go back and play certain sports, such as soccer, football, and play without having to wear the brace, because FIFA doesn't allow braces in professional soccer. Right? Did that answer your question? Okay. Thank you as well, everyone. I appreciate it. As I say, this is available. If you want it, I will provide it to Maritza, and anyone who wants this and wants the reference sheet, or there's a white paper on dynamic bracing that we can also provide that lists these same citations, the journal citations, for you to peruse and increase your learning about this particular subject matter.
Yeah. Thank you, everyone.
All right.
Yeah.
So, Apka Dhanyavad. Thank you. Sure. Yes. Well, it's a lot. Sure. Yes. Sure. If you have any concern, now I'm not sure which particular reconstructive technique that you have. I can tell you that the bone patellar tendon bone, while it's much, much stiffer and stronger in terms of failure rate, the problem is it's too stiff. Its stress shield is secondary structures that provide the secondary and tertiary reflex arc to the hamstrings. And so you don't get a response at all out of the hamstrings. And so you have an increased tendency for some stretch. At least the various types of other tendon grafts and things have a tendency to be a little more flexible and not have that peak pressure that way. And that allows some of the secondary proprioceptors in the knee, the neuroreceptors, to provide that secondary and tertiary reflex. And then you get a little hamstrings response. It's slower, but you get it. And as long as they're not doing violent turning maneuvers, then they can learn to do it. So you want to protect them during, absolutely want to protect them during the maturation period of the ligament. And then you can discontinue at your leisure. Well, it depends on how long you feel it takes for your ligaments to reach at least 80 to 90% maturation. Most of the literature is showing 8 months to a year for that to occur. Okay, if they're not doing demanding activity, they may not need a dynamic brace at all. We make static. Sure, you can do that. And how to adjust it? Yes, of course. Yes. Yeah, they stretched it or they pulled it loose slightly. It happens. Those can be stopped. But this depends upon compliance. So they have to be taught how to use it, how to tighten it, not so much that it becomes uncomfortable, right? And the nice thing about dynamic braces is you can apply that force and extension, and then as they move back into flexion, those forces back away. So their comfort level is increased. They can still get a higher force than they would get with a static brace, but they get the increased comfort of not having that force in a flex knee position when it's not needed. So I think you'll find they will comply better when they're not as uncomfortable from wearing the brace. A lot of them have inherent feels of failing their ligament anyway in the first 2 or 3 months. But you always have those 1 or 2 macho guys who can do anything, and they go out and tear them apart. It happens. Thank you. Welcome. I'm sorry we ran over our time. It's 10:09 now, but any further questions? If not, I'm going to turn it back to you, Maritza. Thank you, everyone. I appreciate it.
Thank you, Gary, for doing this.
Thanks, Gary.
Yeah, I just want to mention thank you for Dr. Ashok for leading this streaming video in OrthoTV. And thank you, everyone, for joining this session. I will share the link once I have it ready. And thank you again for joining. Have a great evening.
Goodbye, everyone. Thank you.
Thank you.
Thanks to thank you, Gary. Thanks to
You're
everyone.
welcome. Thank you.
Thanks, Graham, as well.
Thanks, Dr. Ashok. I think it's a wonderful opportunity for us to.
Pleasure to meet you, Dr.
streaming.
Ashok.
Yeah. Thank you very much, sir.